Thank you so much, Susan, and thank you to all of the participants who are joining us today. As Sue had mentioned, I'm Dr. David Benderson. I'm a comprehensive ophthalmologist. Our office is located at 1200 East Ridgewood Avenue, across from the Duck Pond in Ridgewood. Comprehensive ophthalmology means that we do full service ophthalmology, ranging from routine eye exams to cataract surgery and laser treatments, and medical and surgical treatment of various eye diseases, some which we're going to talk about today. So the topic of the talk today is the aging eye. And as you can imagine, there are so many things that happen to our eyes. It's a pretty complex organ as we get older. And like many other parts of our bodies, we tend to develop more problems with our eyes as time goes on. Um, Obviously, it's impossible to touch upon a huge number of issues about the aging eye, but within the confines of the time we have allotted, I picked some what I thought were some high yield or frequently asked questions or topics related to our eyes as we get older. Um, so the way I've sort of formatted the talk today is sort of what's the deal with XYZ as our eyes get older. So starting off with something that happens to everybody from young children to adults. I'm on Zoom all day. Do I need blue blocking glasses? That's a question I get a lot. So we'll talk about that. Then we'll talk a little bit about how, well, I'm 45. Why do I need reading glasses now? I'm 55. Why are my eyes dry? I'm 65. Why am I suddenly seeing all these floating spots? I'm 70. Why is there all this glare at night? Is it just from these new headlights? And I'm 75. Do I really need to take these eye vitamins? Now, all of these things that we're going to talk about can happen at really at a range of ages, but these are sort of just like a way to frame this discussion about the aging eye, sort of decade by decade. So I like this cartoon here from the eye clinic with the busted up parking meters out front. Um, so blue blocking glasses. I really can't actually see the participants, but you can sort of make a mental note if you raise your hand, if you will, if you believe that wearing blue blocking glasses are helpful. This is something that people ask me all the time. I see these blue blocking glasses advertised. So the story with the blue blocking glasses is they're often related to digital eye strain and computer use. So digital screens, such as the one that you're probably using right now, emit a wide spectrum of light, including blue light. The problems that we encounter from spending time on the screen are actually really not felt to be due to blue light, but due to something we term computer vision syndrome or digital eye strain. And the real causes of this computer vision syndrome are people complain of irritation, dryness, eye strain, glare, discomfort when on the computer are actually several other things, including infrequent blinking. So it's known that if we're reading a book or spending time on the computer, we just blink a fraction of the amount of time that we should be. And as it's an involuntary reflex, essentially blinking, it's pretty hard to force yourself to blink regularly. Second cause is just eye strain from focusing and staring. And finally, glare and contrast issues. Um, so what can we do about this computer vision syndrome? Well, the first thing I always recommend is following something called the 20-20-20 rule. So the 20-20-20 rule means that you take a break every 20 minutes when you're using a screen for 20 seconds and look at something 20 feet away. So it's a good idea, if you can, to look out a window. And what that does is it relaxes the muscles in our eye that help us focus close up. So it gives them a chance to kind of relax and reduce eye strain. I also usually tell people in this time period to close your eyes briefly too, to help them reset the tear film, which can help out with dry eyes. And that brings us to the next recommendation that I have for when you're spending a lot of time on a computer screen, which is using artificial tears. A lot of people who don't have underlying dry eye will have dry eye symptoms when they're on the computer just because they're not blinking as frequently as they should. So I recommend keeping some artificial teardrops, over-the-counter artificial tears nearby, and using them regularly. These could include Systane or Refresh Optiv, TheraTears. Any of those are fine. You want to avoid ones that like Visine get the red out, that are quote unquote medicated, for a couple of different reasons. And preservative-free artificial teardrops are good if you're using them very often. There's really the next thing is sitting at arm's length about 24 to 25 inches from the computer. Most people tend to be a little bit closer, and that just forces our muscles in our eyes that allow us to accommodate or to work to help us focus close up to have to work harder. And so I recommend keeping your computer screen a little further back than you typically would. If you're normally at about maybe 18 to 20 inches, you may be better off actually closer to 24 inches away. Um, and which brings me to the point about the blue blocking glasses. And there's actually not a whole lot of evidence that they're helpful. So anecdotally, I definitely have patients who report that their eyes feel better and less strain using them, and there's probably no harm in using them on the computer. But there's not a lot of solid evidence that they're helpful. Blue light does not cause any permanent damage to our eyes, unlike UV light from when we're out in the sun for an extended time. There's one aspect where blue light really does have an important role, and that's close to bedtime, because blue light can interrupt has been known to interrupt our circadian rhythms. So if you're using a screen close to bedtime, that can really be problematic, and it make it harder for you to fall asleep in the evening. So we recommend avoiding screens at night, and when you do need to use them, use the nighttime mode on your screen. So I'm going to segue next into a somewhat related issue. Is I'm 45 years old. Why do I all of a sudden need reading glasses? I never wore glasses in my life, and all of a sudden I can't see close up. So this cartoon shows somebody wearing all of the different kinds of glasses: distance, reading, driving glasses, computer glasses, and then the glasses to find all the glasses that he needs. So most people who are not nearsighted require reading glasses starting sometime, usually in their early to mid 40s. And what they'll find sometimes, their arms are no longer long enough. They're reading and holding things further and further away, and it's getting uncomfortable. So why is it that people who never needed glasses now require them? And why don't nearsighted or myopic people require reading glasses? So the reason for this is a condition known as presbyopia. Presbyopia is a normal aging process. So when we're younger, the lens in our eye accommodates. There's a muscle around the lens in the eye called the ciliary muscle that constricts, and I'll show you a picture of this in a minute, sort of how, or a slide of how this works, causing the lens in the eye to deepen in size, allowing us to focus close up. However, what happens beginning in our early 40s and worsening until our mid 60s is the lens stiffens, and that muscle lens complex can no longer do what it needs to do to help us focus close up. And that's when you start having trouble focusing at near. So the symptoms for this are just holding material further that you're reading further back, blurry reading vision, eye strain, and oftentimes headaches after reading for a prolonged time. So here's a picture of somebody trying to overcome their presbyopia without bifocals or reading glasses, just by holding their newspaper far away under a bright light. But I guess that would work. So here's a diagram sort of showing what we're talking about with presbyopia. So the top picture is when you're looking at an image, sort of normally a distant image, for example, or near image, the light, which is represented on the left side, travels through our eye, and it goes through the cornea, and then the lens in the eye, forming an image which is focused, as you can see, as those rays of light, those three lines converge on the retina, presenting us with a focused image. When we're nearsighted, when you bring an image closer, you can imagine that image is focused further back, just as it's getting closer to you. So what happens is that when we start losing our ability to focus close up, the lens can no longer deepen. So if you look at the first picture, you can notice that the lens, which is a structure in the middle of that eye, that's sort of a hockey puck kind of shaped thing, is sort of rounder, versus in the second picture, it's flatter. So what's going on in the first picture, the muscles represented by these arrows around that lens are constricting to make the lens bigger, and that's what's allowing that close-up image to focus on the retina. So when we start becoming presbyopic in our 40s, our lens can no longer really do that well, so the image focuses behind the eye. So how do we correct that is by putting a reading lens in front of it, and that's the third picture. That lens on the left side of the picture is a reading lens, and what it does is it pulls the image from behind the retina onto the image, and that's how reading glasses work. And so that's sort of a good overview of presbyopia, why it happens and how we correct it. So here's a question I get asked sometimes. Well, I don't need reading glasses. I'm 55 or 60 and I can see just fine. In fact, I see better when I take my glasses off. When I have my glasses on, I actually can't really see close up, but I take them off and my reading vision is fine. So that is what happens in somebody who's myopic or nearsighted. So when you're nearsighted, what that means effectively is that the light, the image that you're looking at, is focused on the front, in front of your retina. And a simple way of thinking of that is that the eye is just too long. So when we're nearsighted, the light is focused in front of the retina, and we wear a different kind of glasses to focus the light on the retina. However, if you can imagine that you're looking close up, that image is shifted back. So people who are nearsighted, that image, instead of being focused in front of the retina, when you pull the image closer, is now focused on the retina. And that's why people who are nearsighted oftentimes do not need reading glasses and can actually just see better without their glasses on for close up. And that's actually where the term nearsighted comes from. You have near sight, you don't have far sight. People find that confusing and think it's sort of a misnomer, but it's actually not. Nearsightedness means you have near sight, you just don't have far sight. So treating presbyopia, there's a few ways that we can do it. One is wearing reading glasses. That's the most common tried and true method. A second option is doing something we call monovision contact lens, where we take your non-dominant eye and we actually make that eye nearsighted, as we saw in that last picture, and that brings the focus in where it should be for reading. Believe it or not, a lot of people, in fact, most people seem to tolerate that pretty well, having one eye for near and one eye for distance. Not everybody, but in my experience, probably about 2/3 of people that we try monovision with will do well. Their brain will sort of balance the images out and sort of allow the eyes to work together, even though one eye is focused for close up and one eye is focused for distance. You can accomplish the same thing by doing LASIK surgery, correcting one eye for near and one eye for distance. And finally, you can just hold things far away, like this cartoon picture on the right side here. So getting a little bit further ahead, I'm going to talk about the next topic. Is I'm 55 and why are my eyes dry? And this is not to suggest that you can't get dry eyes earlier in life or later in life. You can get dry eyes at any time. I've seen children with dry eyes and I've seen people in their 90s with dry eye, but it's not uncommon in our 50s to start developing problems with dry eyes. So simply put, dry eyes is just an inability of your tears to adequately lubricate your eyes. And this can be because your eyes aren't making enough tears, or the quality of the tears that your eyes are making are not good and they're not providing enough lubrication to your eye surface. It's really common. Up to 17% of people suffer from dry eyes. I think this number is probably a little bit higher. It is more prevalent in women, and it does increase in prevalence with age. Typical symptoms of dry eye include a burning sensation, light sensitivity, redness, foreign body sensation, which is when your eyes feel sandy or gritty, fluctuating vision or blurry vision and glare. A lot of people will report when they have dry eyes, they start reading and everything is fine, and then after about 20 minutes, everything gets out of focus and foggy and glary, and they have to blink a lot to get things into focus. Excess watering, pain, difficulty tolerating contact lenses. Sometimes if you have dry eye, you can get a buildup of stringy mucus in your eye, and just eye fatigue. A typical thing, for dry eye is, just after reading for a long time, just having that sort of feeling like the eyes are burning and out of focus. If it's something that clears up after you close your eyes for a little bit and blink, then very likely it's an eye surface issue such as dry eyes. This is a photograph taken at the slit lamp, which is the piece of equipment that we use in our office to examine our patients. So what we're looking at here is an eyeball, obviously. And what we do in our office is put in a special dye. There's a couple of different ones that we use. This one is called fluorescein dye, and it's a vegetable-based dye we use as an eye drop. And we look with a special blue light, which makes this dye highlight yellow-green. Now you can see in this picture, there's a speckled blue-green or speckled yellow-green appearance to the bottom of the eye, and that shouldn't be there. And that's what we typically see in somebody who has moderately advanced dry eyes. What's happening here is that the epithelium, the surface tissue of the cornea, is becoming dried out and desiccated. And so what's happening is that dye is being taken up by the corneal tissue, highlighting in yellow and green. So that's a telltale thing that we see in people who have dry eyes. So the causes of dry eyes are pretty varied. Simply, it could just be a failure of tear production, not making enough tears. This can be associated with medical conditions, including autoimmune or inflammatory diseases such as rheumatoid arthritis, lupus, thyroid disease, sometimes diabetes, and something called Sjogren's syndrome, which can lead to dry eyes and dry mouth. That can be a diagnosis in and of itself. It can also be secondary to other autoimmune diseases such as lupus or rheumatoid arthritis. Certain medications are known to cause dry eyes, and we see this pretty often. Sometimes, unfortunately, as ophthalmologists, we cause some dry eye because we put people on glaucoma medications that they're on for many, many years. And after a while, sometimes the preservatives in those eye drops or the medications themselves can result in dryness of the ocular surface. LASIK surgery, when LASIK is done, we actually the laser actually cuts the corneal nerves, and that can lead to dry eyes because it interrupts a feedback loop that's important for maintaining your tear film. Um, there are other problems such as fast tear evaporation, if you and mechanical causes such as poor blink or a Bell's palsy, for example. Dry air in the winter, I call winter the dry eye season because in the summer I don't see that many new dry eye patients. In the winter, every day I see people coming in who are complaining of new dry eye symptoms, and a lot of that's environmental, just with the lack of humidity and the dry forced air. Um, Conditions that can cause decreased blinking, we'd already talked about reading and computer use, but also driving, and patients with Parkinson's tend to have a markedly reduced blink rate, which can lead to dry eyes. Poor eyelid position, keeping the tears away from the eye surface. Um, Something called meibomian gland dysfunction and rosacea, which is related to blepharitis. And what that refers to is inflammation along the eyelids, and that can specifically impact the tear producing glands right behind our eyelashes, which are known as meibomian glands. Um, those glands produce a lipid or fatty oil layer of our tear film. And if that is deficient, our tears tend to evaporate quickly. And so the eyes become more dry. It's also something that can lead to styes. So how do we treat dry eyes? Um, we do our best. It's not always easy, and dry eye treatment can actually be a real challenge. The simplest thing to start with is using over-the-counter artificial teardrops like the ones I'd mentioned when we were discussing computer use, such as Systane, Refresh, or TheraTears. There's a number of them out there, with or without preservatives, because if you use them frequently, you can develop a sensitivity to the preservatives. So I usually recommend that patients who are using artificial tears more than 3 times a day switch over to the preservative-free artificial teardrops. Um, Sometimes people need more aggressive lubrication using tear gel or gel drops or ointment for the eyes, especially at bedtime. They are very effective with treating the dry eyes, but unfortunately, they also tend to make the vision a little blurry. There are several prescription medications for dry eyes. Until not that long ago, we only had one, Restasis. Now we have a couple of others, Xiidra or Lifitegrast, and there's a newer one called Cequa, which is another form of cyclosporin that's a little more concentrated than Restasis. We can also place something called punctal plugs, and punctal plugs are very small little basically plastic plugs that go into your tear duct, and that blocks the tears from flowing out of your eyes, keeping the tears in your eye surface longer. Particularly people that have problems with those tear glands, the meibomian glands, omega-3 supplementation with flaxseed or fish oil can be helpful. We sometimes use steroid eye drops, but that's only a short-term solution. Long-term steroid eye drops can have some negative consequences, including elevated eye pressure and cataract formation. But in the short term, we sometimes will use those. Um, there are a few other measures that are mentioned here, including something called autologous serum for extreme dry eyes that's sort of refractory to other treatments. And that actually involves getting your blood drawn, having it spun, and then using the serum to make eye drops. And some of the growth factors in the autologous serum can actually be very helpful for treating dry eyes. We do have a couple of compounding pharmacies locally which do make autologous serum drops, and we do prescribe them from time to time. So moving on to a couple of other issues related to the aging eye. A common question we get is, why am I seeing all these floaters? So I'm 65 now. Why am I seeing floaters all of a sudden? Um, I'm going to break this down into both floaters and flashes, actually. So we'll start off talking about floaters. So when people are referring to floaters, they're usually referring to these amoeba-like spots in the vision that move around. You move your eye, it sort of moves with the eye. Sometimes people will describe it as being a gnat. And I've actually had patients report that they've been swatting in their vision and really thinking that there was something, that they're actually seeing a bug flying around, but they figured out later it's something within their eye. Um, They can be associated with flashing lights in the vision. Um, there's sometimes a sudden onset, sometimes they're more insidious, and they're often due to something called the posterior vitreous detachment, which we'll talk about in a minute. So floaters are due to are age-related changes in the gel in the back of the eye, which is called the vitreous. So the vitreous, when we're born, is this gelatinous gel-like substance that's mostly made out of water with a little bit of collagen and hyaluronic acid. What happens over time is that collagen breaks down into these floaters, what we call vitreous syneresis, and that's what we see as floaters. And part of that process is the liquefaction of that gel. People who are nearsighted tend to develop floaters earlier in life. And these floaters can look like, as I mentioned, amoebas, cobwebs, hair, gnats, or strands in the vision. They're annoying, but they're benign in and of themselves. The treatment for floaters is typically to do nothing. They'll usually get better and become more tolerable, although they can absolutely be a long-term nuisance. There are a couple of treatments for floaters which are pretty controversial. One is something called a YAG vitreolysis. I'm sorry I spelled that wrong. It's VITREOLYSIS, which is a laser. We actually have it in our office, but we don't do it for this purpose, where you actually laser the floaters. And it's controversial because there's risks, including risk of taking a larger floater and creating a bunch of smaller ones, risk of retinal tear. There are some people who do it, but it's a little controversial. Another option is doing something called a floater-only vitrectomy. A vitrectomy is removing the gel from the back of the eye. That's a surgery that's done by a retina specialist. Also, it's considered a last resort. Retina specialists are usually reticent to do this procedure for floaters only, unless it's really debilitating floaters. So they typically will recommend waiting and waiting. And if you come back enough times and it's really bothersome, they sometimes will consider doing it. Um, and finally, you should always get checked out if there's new floaters or a major change to make sure there's not a more serious pathology going on. So speaking of more serious pathology, what about flashes or flashing lights in the vision? Flashes are like these lightning bolts or stars in the vision, and they're a sign of traction or pulling on the retina. They can be associated with something called a PVD or posterior vitreous detachment. Um, they can also be a symptom of a retinal tear or detachment because, again, if there's pulling on the retina, sometimes that means that there's a break in the retina as well. Occasionally, people report flashing lights with migraines. Oftentimes, they describe this as jagged lines in the vision or a heat wave, or sort of like a mosaic or an unusual pattern, which sometimes, but not always, is followed by a headache. It usually lasts about 20 to 30 minutes. So that's a migraine aura. And some people get migraines without headaches. We call those an ocular or an acephalgic migraine. If you do have flashing lights, you really should see an ophthalmologist if there's a change where you're starting to see new flashing lights or if there's a big increase in floating spots in the vision. So the posterior vitreous detachment, or PVD, which I mentioned, is a common cause of sudden onset of flashes and floaters. What this indicates is that vitreous gel in the back of the eye, and I'll show you an image of that in a minute, has separated or pulled away from the retina. It's a common normal age-related process. The vitreous liquefies and it has these pockets which pull on the retina, and that traction on the retina again results in flashes. And when you get a complete separation of that gel, you start seeing more floaters, and we can actually see the vitreous having separated on exam. So something we can actually confirm on exam. It usually happens one eye at a time, but often the other eye will happen in a fairly short course, months, years afterwards. Risk factors for a PVD. It's usually in older patients, but I've seen it in patients including teenagers, especially people who are more nearsighted, which I mentioned is a risk factor for this. Typically, it happens in people in their 50s or beyond, and by 70 or early 70s, most people have already had a PVD. It's more common if you've had a trauma to the eye, which can jar that vitreous loose and cause it to separate. It's also more common following an eye surgery or an eye laser treatment, including LASIK surgery. So the symptoms of this PVD include photopsias or flashes, which are those camera-like bright lightning bolt flashes in the vision, usually in the periphery. They're often worse than dim light, so at night, for example, and they're usually associated with new or worsening floaters. In fact, sometimes people will just get floaters and no flashes, so that's why we recommend, if you're having new floaters or big increase in floaters, getting checked out. So what are the problems with the posterior vitreous detachment? The biggest concern with a PVD is the risk of developing a retinal tear. And about 10% of the time, people with a PVD will develop a retinal tear. So that's the textbook answer, is 10%. Most ophthalmologists that I know consider it probably to be more along the lines of about 5%. If a retinal tear is caught early enough, it can be treated in the office with laser by a retina specialist. If it's caught too late, or if it progresses quickly, sometimes there's no really opportunity to treat it early, because it just progresses, it can cause a retinal detachment. Sometimes as the gel, the vitreous, separates from the retina, it can cause what's called a vitreous hemorrhage, or bleeding in the back of the eye. That occurs to some extent about 7 to 8% of the time with a vitreous hemorrhage. I'm sorry, with a PVD. And if there is hemorrhage with a PVD, there is a much higher risk of there being a retinal tear present. So if we see bleeding in the back of the eye, we're always looking pretty closely for a retinal hole or a tear. When there's hemorrhage, we're looking extra close. And I tend to if I see somebody with a PVD, a vitreous detachment with a hemorrhage, if I see a retinal tear, I'm going to send them to a retina specialist to laser it. And if somebody has hemorrhage associated with a PVD, if I don't see a retinal tear, I typically will still send them to a retina specialist, because there is a reported figure of as high of a 75% risk of having a retinal tear if there is hemorrhage. In my experience, if I don't see one, there usually isn't one there. But because of that high figure, of 75% having been reported in some papers, I usually send patients who have a hemorrhage with a vitreous detachment to a retina specialist if I don't see it, for a second opinion, for a second look. So what to do if you have new flashes or floaters? Typically, we recommend being seen usually within 24 hours. It could possibly be a little bit longer if it's over the weekend, depending on how typical the symptoms are and other associated symptoms. If we find that there's a vitreous detachment there and no holes or tears, what we will do is then redilate that eye in 4 to 6 weeks later to make sure the retina remains attached. If there are any retinal tears present, they should be lasered. And basically, we review the warning signs of a retinal detachment. So we'll tell you after you leave, if you start getting a big increase in flashing lights, or a lot of new floating spots, much worse than you were seeing before, that you should come back in or call us immediately. So to kind of put a picture on this, this is what's happening when you develop a posterior vitreous detachment. So if we're looking from left to right, this is a cross section through your eye. The cornea, the clear front of the eye, is on the left, and then the iris behind that, oval structure, is the lens, which is held in place by what are called zonules. And the red tissue in the back is the retina. The retina is actually not red; it's the blood vessel, the blood supply below it, called the choroid, which gives it the red appearance. But the retina looks red. And in front of that, you can see this substance which is separating from the retina in the top of the picture, and that's that vitreous of the gel. So you can see that it's liquefying and pulling away from the retina, and that is a picture of a vitreous detachment. These are actual photographs of what we see, at least 3 of the 4 are, when you have a vitreous detachment. And what you're looking at on the top 2 left images is a photograph that's centered on that vitreous. So in the very back, you can see a fuzzy circle with some red things coming off of it. That is apologize for my dog. That is the optic nerve with blood vessels coming off of it. And that spot overlying the optic nerve, it looks sort of like a little amoeba like circle with a clear center. That's actually what we see when you come in and you have a posterior vitreous detachment. We call that a Weiss ring. There's a little bit of another picture of the vitreous on the right side separated from the retina. And on the bottom left, this is showing the process by which a retinal tear can occur when you have a posterior vitreous detachment. So what you're looking at here is that gel pulling on the retina, and actually that point of attachment there is actually an area where it is pulling a hole in the retina, and you can see there's sort of a flap there. So what can happen if that is not treated with laser is that more vitreous fluid can get underneath that flap and result in a detachment of the retina. So that's the concern when you have a posterior vitreous detachment. So we have 2 more topics to cover today, and then we'll take some questions. So the next topic is, I'm 7 years old. Why is there so much glare now? Is it just these new headlights? Is it because everybody's driving an SUV now except for me? And this is a picture, an image of what it looks like if you have glare at night and you're driving. It can really be a major, major problem, to the point where a lot of people end up not being able to drive at night, especially in the rain, because of this glare. So what we're talking about here is cataracts. So so here is a cartoon related to cataracts. Um, I see so much better now after cataract surgery. And wow, you're bald. I haven't had that one, but I have had many patients complain to me after cataract surgery that they can see wrinkles that they didn't know they had, and a couple have even asked me to put the cataracts back afterwards. Um, so a cataract, which is typically what causes this onset of glare in our 60s or 70s or older, is a progressive opacification of the lens of the eye. It's usually age-related, but there are some other causes, including trauma, diabetes, certain medications, especially steroids, congenital. Some babies are born with cataracts on rare occasion, and sometimes after other eye surgeries. Cataracts typically start around age 60, though they do not become significant usually until a little bit later, although many people have significant cataracts earlier than that. I've done cataract surgery on people all the way from age 18 through 90s. But typically, a more typical time for starting to develop the early beginnings of cataract is early 60s, are not necessarily symptomatic then, but we start to see them. And then oftentimes in our 70s, we may need 70s or 80s, may need cataract surgery. And they're not really an issue at all until they're visually significant. So just having them there is not problematic. This is a picture of a cartoon cross section of the eye. And again, I wanted to show a representation of what we're talking about with the cataract. So that structure labeled the lens, that's your lens, and it's a clear crystalline structure when we're born. And then as it opacifies as we get older, and that is the cataract. So the cataract, some people often confuse it and say, I have a cataract, and the cataract needs to be removed, but can you leave my lens or whatever? But the cataract actually is the lens. The cataract is nothing more than your lens becoming opacified. So it's one and the same. An opacified lens is the cataract, and we remove that whole lens when we do cataract surgery. Typical symptoms of cataracts include blurry vision, glare and halos, and that's, in my experience, by far the most common indication for needing to do cataract surgery is glare, especially while driving at night. Needing more light to read, and colors appearing dull and faded. Um, I have some really nice images here of cataracts. So the cartoon on the top left shows a normal lens, which you can really barely see it. It's pretty clear. And then the one next to it, that overlapping eye, you can see that sort of whitish haze, and that's the cataract. The rest are photographs. The bottom left, this is what we call a white cataract, and you can imagine it's pretty hard to see through that. In fact, I just this morning did a number of cataract surgeries, and one of them was on a white cataract like this. A patient with a cataract like this might only be able to see your hand moving in front of them. They probably won't even be able to count fingers if you hold fingers up in front of their face. It's very rewarding when we remove those. The patient who I operated on this morning has this in both eyes and was amazed that he could even just count fingers immediately after the surgery. On the right side is a fairly dense age-related cataract. It has a yellow-orange appearance to it, as you can see. It's that structure behind the iris with that orange glow. Normally, again, it's a fairly clear structure of the lens. So the way we treat cataracts is by doing cataract surgery. The time to do cataract surgery is when your cataracts are interfering with activities of daily living. That's really the indication for doing it. There isn't a magic number. People sometimes refer to, oh, my cataracts have to be ripe. What we think of, we don't really, you don't use that. We don't, as doctors, use that term cataracts being ripe too often. At least I don't. But the way I think of it as quote unquote being ripe is when it's causing problems with your activities of daily living that can't be corrected by glasses or contact lenses or any other measures. So if you're having trouble driving at night, even with the best glasses, driving at night's problematic, or you need a ton of light. Even when you have all the lights cranked up, you're having a hard time reading or doing things that you like to do, whether it's watching TV or seeing theater. Um, and if we typically do the cataract surgeries, I usually do them if both eyes are ready, and they're not always ready at the same time. Sometimes it could be years before the second eye needs to be done. But if they're both ready to have cataract surgery, I usually do them 2 weeks apart. Some people do them 1 week apart. Some people do them a month apart. There's some leeway as to that. And rarely they're done the same day. That's unusual. There are some people who do it that way, but it's pretty unusual for a number of reasons. Um, we remove the cataract, then we've always put in a clear artificial lens, which is tailored to the power of your eye. Otherwise, you would typically need Coke bottle glasses to see after cataract surgery. So we do measurements before the surgery to determine what kind of a lens to put in. Cataract surgery is common and safe. The safety profile is quite good. The success rate is very, very high. The complication rate is very low, but there can be complications. Risks of the surgery include bleeding or infection. Those things are unusual. Need for more surgery, loss of vision, extremely unusual, and sometimes delayed healing. Sometimes it does take certain eyes a little longer to heal up. So the risks with any operation, and cataract surgery is no different. Most people do very, very well with cataract surgery. It's a same day outpatient surgery. I operate in the Lucko Pavilion, an outpatient surgery center. The way that it works typically is we put an IV in, we dilate your eye, give you a very light sedation. You'll hear us talking, but be totally comfortable during the surgery. It's not painful at all. We can put you to sleep if you need to, but that's really few and far between. It's not a laser surgery, but there is something called laser assisted cataract surgery, where the laser is used to assist in certain steps of the operation. A typical cataract I can do in somewhere from 9 to 15 minutes, typically, sometimes a little bit longer. So it's a pretty quick and successful operation. When we do the cataract surgery, as I mentioned, after we remove your lens, we put in a new lens implant. And there are some options as far as what kind of lens implants to use. Conventionally, we place what's called a monofocal lens implant in, and that is a lens that has a single focus, meaning you can focus for close-up, or you can focus for distance, or we can do monovision, as we discussed earlier, one eye for near, one eye for distance. Those lenses do not offer any ability to see both near and distance unless you do monovision. One eye is each eye is doing something different. So if we correct you for distance, for sure you're going to need reading glasses. I shouldn't say for sure. There are rare cases where surprisingly some people can see without reading glasses with a regular lens implant. It happens sometimes. It's always a pleasant surprise, but typically it's not the case. If we get you seeing for distance, you're almost certainly going to need reading glasses with a conventional implant. If you have astigmatism, we can correct that by putting in something called a toric, or an astigmatism correcting lens implant. And astigmatism just means that your eye is shaped a little more like a football than a basketball. So we use just a different kind of lens implant to correct that astigmatism. Finally, there's a not new anymore, but new-ish category of lenses. The actual lens implants are new all the time. There's every year, it seems like, or a couple of years, there's a new breakthrough in these lens implants, and there was one recently. And these fall under now two broad categories. One are what we refer to as multifocal lens implants. These are lenses that have multiple focal points. So they basically have little rings on them, and I'll show you a picture of that in a minute, which split the light. So some of the light coming into that lens is dedicated to your distance vision, and some of it is for the near vision. One that I've been using recently with some frequency and great success is something called the PanOptix lens. In fact, I put one of those in today. The PanOptix lens is the only true trifocal lens that's approved in the US. So the PanOptix lens gives close-up, intermediate, and distance vision, and most of the patients we put them in are independent of glasses. It's never a guarantee that that's always going to be the case. There's still a chance with any of these lenses that you still might need some glasses, but you're much less likely to need them, you're much more likely to be independent of glasses for more situations with a multifocal lens implant than with a conventional implant. Another option is something called the Tecnis multifocal, which is a little different than the PanOptix. They have various options for that to correct near or intermediate as well as distance. The next category is something called the extended depth of focus lens. And the newest lens implant, I was the first person in New Jersey, in the area, and I believe possibly in the in the greater New York City region, to place this lens recently, is something called the Vivity lens, which was just very recently approved by the FDA. The Vivity lens, it works differently than those other multifocal and even the other enhanced depth of focus lens. So the Vivity lens, and I believe I'll have a picture of that in a minute, basically is a lens that creates a broader wavefront of light. So what that translates to is very good distance vision, and it gives good intermediate computer range vision. It is not great for close-up vision unless we leave you a little bit nearsighted. So when we put the Vivity lens in, I recommend this lens for people who spend time on the computer, or something at that distance, and really don't do a lot of close-up reading, or if they do, don't mind putting on maybe a small reading glass like a +1 for close-up reading. In my reading of the literature and my personal experience, it's very good for intermediate, but not great for close-up. But the big benefit to the Vivity lens over the other multifocal and extended enhanced depth of focus lenses is that it doesn't have these rings on it that can create glare or halos. So the risk of glare halos with the Vivity lens seems to be comparable to a conventional implant. And that has also some other benefits. There's certain conditions where we probably wouldn't recommend putting in a multifocal because we don't want to degrade the quality of vision. And the Vivity lens may not have that degradation as far as risk of glare or halos. Um, these are some pictures that are a little bit faint of different kinds of lenses. So the lens on the top left is what's called a diffractive lens, and that's like an example of a sort of a multifocal lens implant that has those rings that split the light for near and distance. The lens on the bottom left is what's called a toric lens, and if you look really closely, so the center circle is what's called the optic, which gives us the vision. Those two arms that look like the Hawaiian punch guy from those old ads are called haptics that hold the lens in place. And then if you look carefully, there's three dots at the junction of that arm and that lens optic, and that indicates that it's a toric lens. And that those dots are where the steepest part of the astigmatism is, and that's how we line it up. The lens on the right, if you look really carefully, I'm not sure how well this transmits, there's a very, very faint circle in the center, and that's sort of the central button of the Vivity lens that I was just discussing, where it doesn't have those rings that distort the vision, but still allows us to have some improvement in intermediate vision as well as distance vision. So that's sort of an overview of cataract surgery and some of the lens implants that are available to us. Now, all of these lenses have pros and cons. The multifocal lenses and the torics are not covered entirely by insurance, so there's an additional cost for them. And again, the risk of glare halos can be a concern for some of the multifocal lenses. So there's always a compromise. If we give you good near and distance vision, the price to pay for that with for example the PanOptix lens is there is a risk of glare halos and a little bit of a diminishment perhaps in the quality of vision compared to a conventional distance only correcting implant. The Vivity lens, the benefit to that again is good intermediate vision. The drawback is the cost, not covered by insurance, and it does and it's not, in my experience at least, is not great for close-up reading. It's just very good for distance and intermediate. The final topic that I want to touch on today is the last question. I'm 75 years old. Do I need to take these eye vitamins? And what about these eye injections? So here's a picture. I hope I'm not grossing anybody out too much with this photograph of somebody getting an injection in their eye. So what we're talking about with these questions is age-related macular degeneration, or AMD. So AMD is a leading cause of vision loss for people greater than over 50 years old, affecting at least 11 million people in the US. I think it's probably greater than that. In fact, I'm sure it must be. It causes blurry and reduced central vision and typically spares the peripheral vision. The severity varies from extremely mild with no significant impact on vision at all. We see a lot of people every day in the office that have macular degeneration that has virtually no impact whatsoever in their vision, and many of those patients don't go on to develop any visual problems from it. On the other end of the spectrum is severe macular degeneration, which can cause central vision loss for a couple of different reasons. The actual underlying cause of macular degeneration is not entirely clear. It's almost certainly multifactorial. There's some genes associated with it. Having a strong family history of macular degeneration is a risk factor. There are some environmental factors. Smoking is a risk factor. Diet comes into play with this as well. Age certainly greater than 60, and as we get older, the incidence of macular degeneration goes up. Having a family history, Caucasian race, obesity, again, smoking for sure is a risk factor for macular degeneration. High cholesterol, hypertension, and heart disease are all risk factors. There are two types of macular degeneration. There's the dry type and the wet type. So the dry type of macular degeneration is by far the most common. It accounts for at least 80% of cases. And with dry macular degeneration, and I'm going to show you some images of this in a minute so you see what we're talking about and what it looks like, you get these clumps of protein in the back of the eye, which are called drusen, and then thinning of the macula. That macular thinning can be very severe. So the other form is the wet form, which is less common, but usually more serious. In this form, which starts out as a dry disease typically, you get these new abnormal blood vessels growing under the retina, which cause a leakage of fluid and blood, and then ultimately scarring in the retina. Now, while wet macular degeneration is the less common form of it. It accounts for the majority of vision loss from macular degeneration because of the severity. There are certainly people that have dry macular degeneration that also lose vision due to severe atrophy and thinning of the retinal tissue without developing bleeding or the wet form. So that does happen as well. These are some images of dry macular degeneration. So on the left, that is a picture, is the same picture twice. I think I meant to copy two different pictures, but that's a picture of a retina with these yellow spots. So what we're looking at is the center of the macula, where we have our center vision is sort of right in the center. Off a little bit to the right, that round thing is the optic nerve. And those little yellow spots are these deposits that we call drusen. And that's a hallmark feature of macular degeneration. On the right side is a cross section through the eye. This is actually something we do in vivo in the office. We actually can take a picture called an OCT. That's what this is of your eyeball. It takes a matter of seconds, and it'll actually scan through the retina, and we can actually see what's going on a structural level, microscopic level. And those little lumpy, bumpy spots that you can see sort of on the bottom, those little hill-like things, are actually those drusen. And so here is a picture sort of contrasting wet and dry macular degeneration. So on the left side, we have a picture of dry macular degeneration where you have atrophy of the retinal tissue. And that's where in the center of that image, that OCT, that scan on the bottom, it just becomes thin all of a sudden. And that drop out there is atrophy of the retinal tissue. That's right in the center of this patient's vision. So this illustrates that you can have severe complications from dry macular degeneration that can lead to vision loss, although most people don't have this degree of it. And then the drusen are those little pigment clumps that you can see, are those little clumps of material that you can see underneath the retina. In contrast, to the right of that, we have a picture of macular degeneration where this patient has actually had new blood vessels growing in the retina, causing bleeding, which you can see. And on the OCT image, you see that elevated spot, and that is fluid and blood underneath the retina. And on the right side, that's a picture, a photograph of a retina that has fluid and blood present from macular degeneration. So the symptoms of macular degeneration vary wildly. A lot of people who have dry early macular degeneration are totally asymptomatic. When it does become symptomatic, the symptoms include distorted vision where lines no longer look straight. Difficulty adapting to dim light is actually something we see oftentimes. Even it's been recognized as a symptom that can develop before we actually see signs of macular degeneration in your eye. So that can actually occur before we actually can see it in your eye. And there's companies looking at ways to sort of use dark adaptation to diagnose early macular degeneration. Trouble recognizing faces because of central distortion and blind spots in the vision. It's oftentimes not symptomatic until it's very advanced. And it's diagnosed by exam and doing special ancillary tests like the picture that I showed you, as well as something called the fluorescein angiogram, which is a dye test where dye is injected in your arm and it's photographed as it travels through the eye. The treatment of macular degeneration depends on what kind it is. So for dry macular degeneration, there is no real treatment for it, but it's more about modifying the risk. So for dry macular degeneration, if it's mild, there's really nothing to be done about it except for having a diet rich in green leafy vegetables, not smoking. I always tell people if you smoke, quit. If you don't smoke, don't start, and monitoring the vision. If you have moderate dry macular degeneration or worse, and we have very specific clinical criteria to differentiate these things, we recommend starting on vitamins called AREDS2 or age-related eye disease study 2 vitamins, which have been shown in very good studies conducted by the National Eye Institute at NIH to lower the risk of developing the wet form of macular degeneration significantly. These vitamins contain vitamins C, E, zinc, copper, lutein, and zeaxanthin in very specific doses. It's usually 2 pills a day. If you have the wet form of the macular degeneration, we recommend those vitamins, as well as doing something called anti-VEGF treatment, which are the injections that I showed in that picture. And there's a number of them out now. There's 4 of them in the US. So the anti-VEGF, VEGF is something called vascular endothelial growth factor, and it's a protein that promotes the growth of new abnormal leaky blood vessels in the eye. Medications, which are known as anti-VEGF, are monoclonal antibodies which block this protein. So it basically blocks this protein, so it no longer has the power to cause bleeding and swelling and leakage of blood vessels in the back of the eye. The history of how this was sort of discovered and its use for ophthalmology is very interesting. There's a medication called Avastin, which has been used for a long time for colon cancer and other types of cancer. Very smart ophthalmologists, a group of ophthalmologists led by a guy named Dr. Phil Rosenfeld in Miami, um, realized that some of these patients who were getting Avastin for colon cancer were having improvement in their macular degeneration, which never happened before. It was basically, it was essentially untreatable. It was not, none of the treatment modalities we had before this really worked well. And this is something that's come about since the time when I was a resident. So this is relatively new. And, and by relatively new, I mean over the last 15 years. These injections, we've learned, have to be repeated regularly. Otherwise, the bleeding will come back. So unfortunately, these injections are every 4 to 12 weeks, depending on which one and your response to it. So this is a picture of an injection of the anti-VEGF medication. It's done in the office. It's a pretty simple thing. It sounds barbaric and terrible, but actually it's generally not very painful, and it's very quick with a very small needle. And people are surprised at how well they tolerate it. And most patients really don't find it to be nearly as difficult as you'd think it'd be to get these injections. Are pleasantly surprised that it's not that bad for something you have to do fairly regularly. Um, so that concludes my talk today. So I'll be happy to take some questions. I just added a little cartoon on here about the importance of getting regular eye exam, because a lot of these things, macular degeneration and cataracts, and then some other things that we didn't discuss today, for example, glaucoma, are things that typically won't be noticed by a patient until it's too late. Things like, so it's important to get a regular eye exam. We recommend at age 40 if you haven't had, just getting a baseline eye exam then, and then probably a yearly eye exam as we get older and have a higher risk for developing some of these conditions that I talked about. So I'll be happy to take any questions that you may have at this time. Thank you
Okay,
very much.
thank you so much,
Sure,
Dr.
my
Benderson. It
pleasure.
was just great and so comprehensive. So I'm going to, trying to get a lot of questions.
Okay.
So we do have some questions. I know you may have covered a couple of things. I'm just going to sort of, just go over them, like what's been asked a few times. So how does rosacea cause dry eye? Is there
Ah,
a
great
connection
question.
there? Great.
There absolutely is, yes. And rosacea is a very very common and often overlooked cause of ocular surface disease, including dry eye. So rosacea, for those who aren't aware, is basically a condition of the skin, and it oftentimes affects our face, and it's characterized by dilated sort of abnormal blood vessels on your cheeks and nose. Um, Bill Clinton, I believe, has rosacea. There's a lot of W.C. Fields or people that you may recognize as having had skin rosacea. It can also affect the eyelids, and that's where the ocular surface comes into play. So when you have a rosacea involving the eyelids, what happens, that affects these tear-producing glands that I spoke about earlier, the meibomian glands, and you end up with a lack of that lipid or fatty oily layer in the tear film, and people with ocular rosacea end up with tears that evaporate too quickly, and what we refer to as evaporative tear disease. It can also frequently lead to styes because it affects these tear producing glands that can become blocked and have styes form. It can cause crusting, flaking of the eyelids, chronic eyelid redness, and it can also cause very red eyes. So it's also a cause of just generally red eyes and dry eye. So treating rosacea or ocular rosacea, there's a few ways that we can go about doing that. We do a lot of the same things that we do for blepharitis or eyelid inflammation in general, because rosacea eyelid disease is a form of rosacea of blepharitis, and that includes doing warm compresses the eyelids every day, doing things like baby shampoo eyelid scrubs, commercial lid scrubs such as OcuSoft. There are some hypochlorous acid sprays available now, something called Sterilids, and there's another one called Avenova that can be helpful. Um, Oftentimes, in some cases, doing systemic treatment can actually be helpful for the ocular rosacea as well as the dermatological, the skin rosacea, and those are medications such as doxycycline. There is a low dose, long acting form of doxycycline available called Oracea, which unfortunately insurance companies oftentimes don't cover. The thought with using doxycycline for ocular rosacea is not that it acts as an antibiotic, but that it acts as an anti-inflammatory. And We used to prescribe fairly high doses of that, like 200 milligrams twice a day. But the problem is long term, it can cause some side effects, upset stomach, it can cause your skin to become light sensitive. So I'm a bigger fan of using the lower dose Oracea when it's available, when insurance will cover it, in conjunction with the dermatologist. We sometimes use azithromycin eye drops for this as well. The problem with ocular rosacea is that it's a chronic condition and it's not really a cure for it. We can do our best to treat it, but it's a chronic, ongoing, recurrent issue.
Okay, thank you. That was going to answers my next question. So somebody had written here, I have a macular pucker and need cataract surgery because I can no longer drive at night. Does the macular pucker create a risk factor regarding the surgery and all that? So that was
It's
it.
an excellent question. So there's a couple of issues to unpack when you're dealing with a macular pucker, and a cataract. Macular pucker refers to a wrinkling on the retinal surface, and that can cause distortion to the retina. I'll try to find a picture here, of the retina. So this is a cross section through the retina, and we can ignore the lumpy, bumpy area. And this is a picture on the right. But imagine somebody who has an epiretinal membrane, the surface of the retina is really wrinkled, and that can cause distortion and swelling, and just it can cause what we call metamorphopsia, where objects appear to be distorted, lines are wavy. And so a lot of times that occurs around the time when you have a vitreous detachment, which is also around the time you develop a cataract. So part of the question we have when somebody comes in with an epiretinal membrane and a cataract is how much does each problem account for their vision issues. So because we want to give a reasonable idea of what's going to happen after they have cataract surgery, what's going to happen if they need the wrinkle treated. So oftentimes, patients that have this as well as a cataract will see along with a retina specialist, and try to determine, what reasonable improvement can be expected after cataract surgery. And so the retina specialist will sometimes be able to help us give the patient a sense of whether the cataract surgery alone is going to be enough or whether they're going to need more surgery. Because a lot of times an epiretinal membrane, even ones that look pretty bad, sometimes the vision is not always that bad from them. And for example, if there's an epiretinal membrane and the vision is better than 20/40, a lot of times we don't recommend, and retina specialists oftentimes don't recommend doing surgery for that, because there's not necessarily a clear chance of improvement, unless, for example, there's a lot of distortion in the vision as well. So as far as what to do first, the cataract surgery or treating the retina with what's called a membrane peel, which is done by a retina specialist, typically we recommend seeing the retina specialist, having them on board before doing the cataract surgery. But in most cases, if there's significant cataract, both the retina doctor and the comprehensive ophthalmologist usually recommend doing the cataract surgery first for several reasons. One is that sometimes, and I've had this happen many times, where I've seen people that have a pretty bad wrinkle in the retina and they have a cataract, and I say, well, get rid of the cataract, but I'm fairly certain you're going to need to have that wrinkle repaired afterwards. And then we get rid of the cataract and the vision is actually pretty good and they don't need to do anything else. So that's one reason why we recommend doing the cataract surgery first in most situations. The second is that doing a vitrectomy or membrane peel is inevitably going to make the cataract significantly worse. And the cataract can be a little harder to remove after vitrectomy has been done, because there's no longer the support from the vitreous behind that lens after you've had the vitreous removed, which is the surgery for the epiretinal membrane peel. Now, I'm very comfortable doing cataract surgery in people who've had the vitrectomy, but the thought is that there is an increased risk of complications after you've had a vitrectomy to cataract surgery. I find that it can be safely done, but it's a known risk. And then the last issue is that doing a retina surgery like a membrane peel is an extremely delicate surgery done by a retina specialist. And we feel that the view that they have during the surgery is really critical, or very helpful to having a good outcome for their surgery. So if we remove your cataract before doing that membrane peel, it gives them a better chance of doing a successful surgery. That's how we think about it, is that they're going to have a much better view of the retina and it's going to make their surgery easier. So if you do the cataract surgery first, there are no additional risks to doing the cataract surgery. It's the same cataract surgery we do if you didn't have a wrinkle. But the biggest concern is just knowing that the vision may be limited afterwards because of that wrinkle, and it may require further surgery.
Okay, thank you.
Sure.
You have time for a couple more questions?
Absolutely.
I'm trying to. Okay, so questions about sunglasses and different, someone asked about like different shades in eyeglasses and
That's a good
anti-glare.
question.
So that was a question. Yeah.
I should have mentioned that actually under macular degeneration and cataracts, because wearing UV protection is very important for lowering the risk both of progression of cataracts and also lowering the risk of age-related macular degeneration, as well as things like ocular melanomas. So sunglasses, the important thing with sunglasses, as far as the health of your eyes, is not the shade or the color. The important thing is having something called UV 400, and that refers to a specific wavelength of light. So if you get sunglasses, it doesn't really matter the shade, the tone is just whatever you're comfortable with. But they should have what's called UV 400 blocking that specific UV light. By the way, many contact lenses and glasses that are not sunglasses will actually have that UV protection too. So by wearing contacts or glasses, you're oftentimes will get that protection as well. Larger sunglasses, obviously, they block more light or better as far as protecting your eye from that UV light. Um, and sometimes the glasses won't say that they're UV blocking. They don't have to be expensive glasses. They can be inexpensive glasses as long as they specify their UV 400. Um, and so that's sort of the main thing. The most important things with sunglasses are UV 400. If you wear sunglasses and they don't have UV blocking, believe it or not, it's actually worse for your eyes than not wearing sunglasses at all. The reason for that is if you're wearing a pair of dark, sunglasses that don't have UV protection, if you're out in the sun, you're wearing sunglasses, naturally what's going to happen is your pupils are actually going to be more dilated than they would be in the sun otherwise, because not as much sunlight. So the sunlight causes your pupils to constrict. You're wearing sunglasses, your pupils are not going to be as constricted. So if the sunglasses don't have UV protection, what's happening is that your pupil's bigger, more light is reaching the retina, and it's not UV filtered. So actually wearing sunglasses without UV filtering is potentially worse for your eyes than not wearing sunglasses at all. So it's really important when you wear sunglasses, you wear UV 400.
Wow, that is very interesting. Okay, so just a couple more. Few people are asking about sequa
Sequa,
and
yes.
sequa,
Yeah, for
and
sure.
if their eyes
Yeah.
are still dry, even using that, what
Yeah.
would be sort of the next?
So Sequa is related to Restasis, which we mentioned before. Restasis was the first prescription in dry eye medicine. It's a cyclosporin, a medication that's used systemically for a number of things, including after kidney transplants and things like that. But it's used as an eye drop. It works on the immune system on your ocular surface, and it decreases inflammation on the eye surface, which is associated with dry eyes and helps our eyes have healthier tears. So Sequa is a newer form of Restasis that is of cyclosporin eye drops. And it's a higher concentration than Restasis. So it's a more potent cyclosporin drop than Restasis. Um, so the any of the cyclosporin drops, Restasis, Sequa, and there's going to be some new ones probably coming down the pike in the future. They take time to work. They take about 6 to 8 weeks until they even start to have an effect. They don't work immediately. It takes a long time for them to start to work. So the first thing with Sequa or Restasis is to really give them time. The second thing is I for sure have a number of patients that have gone on the prescription medicines for dry eyes, whether Restasis, Sequa, as well as Xiidra, where they really don't work that well. So they work for most people, but unfortunately they don't work for everybody. Some people will see an improvement in their exam, but their eyes don't feel better. Some people we won't see an improvement at all. And again, the majority of people we do find have an improvement with those drops, but certainly not everybody. A couple of things to do if you're on those prescription medications and they're not working. One thing is just going back and making sure that the diagnosis is correct, that there's nothing else contributing that might be treated, such as blepharitis, which can frequently contribute to dry eyes. And then the other thing is if it fails, there are other things that can be done, but dry eyes can actually be really tricky. And I find, unfortunately, that a lot of people we treat for dry eyes, it's not an easy condition to treat for many people. Some people do great. We put them on Restasis or Xiidra, artificial tears, the eyes feel better, and end of story. But a not small subset of people really don't respond as well as we'd like to these medications. In that case, the question, I guess, is really whether it's, number one, is it worth staying on it? Would you be even worse off without it? And number two, what else to do? And the other things would include just continuing on frequent artificial teardrops, considering something like punctal plugs, like I mentioned, and block the area where the fluid flows out of the eyes, treating any underlying conditions such as blepharitis that might be contributing. Um, and there are some other things that are less frequently done, such as for more severe cases, that autologous serum eye drop that I mentioned, basically using your serum to treat the dry eyes. And there's something called Lacrocert, which is basically it's a little capsule that we put underneath your eyelid. I sometimes use that, and it provides like a constant artificial tear to your eye, so it dissolves throughout the day. So there are definitely other things we can do, but I will say, unfortunately, uh, patients that have not had success with Xiidra, Restasis treating the dry eyes, unfortunately, it's not that unusual. Dry eyes can be really difficult to treat, and oftentimes the response to some of these medications is not as satisfactory as we'd like.
Okay, and just two more. Somebody had asked, I'm actually curious, how often do cataract lenses have to be replaced?
Good question. The new lens implants that we place after cataract surgery never have to be replaced. So the great thing about cataract surgery, it's a one-time thing. Um, that lens will outlast all of us. They're made out of really good acrylic materials, and they'll never have. There are only very rare cases they'd have to be replaced, and that would be, for example, if there was a trauma or some other condition that caused the lens to become dislocated, and a new lens might have to be sutured into place. Um, so that if there was trauma to the eye, or if there was a problem where a patient, let's say they had a multifocal lens implant and they were really, really bothered by glare and might need a lens, we call lens exchange then. But those things are really unusual. And typically that new lens implant, when the cataract surgery is done, the cataract never comes back, the lens never has to be replaced.
Mm.
About 20-25% of the time after cataract surgery, a film can form behind the lens implant. And that's a really easy fix. We do something in our office called the YAG capsulotomy. It's a laser to zap that film behind the lens implant. But the lens itself typically will never have to be replaced.
That is good news.
Yes, yeah.
Well, I think we're going to wrap it up. Just thank you so much. It was
My
such a
pleasure.
excellent comprehensive program. We learned a lot and very interesting as well.
Thank you.
So just a